Hi there, everybody. Welcome to our plenary session. We'll be starting shortly. We're just going to give you a moment to get yourself into the room and get orientated. It's a beautiful sunny day here today. And we've got some brilliant conversation we're going to have over the next hour, but we'd like you to be part of that. So as you come in, if you can get yourself over to www.slido.com, and today's session, I believe, is Helm 5, I think, Gweno, but you can tell me if that's wrong.
Correct. I'll put it in the chat now as well. Brilliant.
So it's Helm 5. If you go there, you can do your questions and answers there, but you can also use the chat function. Please do be as chatty as you like. We are interested in hearing from people today. So yeah, go over to www.slido.com, code HALN5, that's HALN 5. So just a few bits of housekeeping as we come into here. Do say hello in the chat function. We are recording this session so that we can share it with other people who can't make it today. So if we'll be doing that throughout the session, so that's there. But what we want to do really is to spend a bit of time hearing from our speakers today. So a few people here with us today. So if we just move on to who we've got here today. So we've got Julia here with us, who you've seen earlier in the week. And if she's the Lennon of this, we've got also the McCartney in Michael Wood, who also opened the show at the start of the week with us. So you get to open the show and close the show. And we've also got with us Sara Bordoley, who's our third Beatle today, the Health Inequalities Leader at NHS England and NHS Improvement. And we're hoping Jagtar Singh will be able to join us. I think Jagtar's been a bit delayed though, so he may or may not be able to join us in this session. But if he does, we'll look forward to having him. If not, I'm sure we'll crack on with a great set of discussions in the meantime. So I'm going to turn over to my colleagues today who are speaking with me. So Julia, Michael and Sara, and I'd like you to say hello. I'd like you to introduce yourself, and I'd like you just in that time also just to say three things. Just if you could tell people why we're bothering to listen to you today, so what you're working on and why you've come here today. Something about what you're most excited by, and where you think the biggest opportunity might be. Just a couple of minutes each, and then we're going to get straight into questions. So please do start asking your questions for the panel in the meantime. I'm going to go to Sara first because we haven't heard from you this week. Then I'm going to go Michael and then Julia.
Thank you, Michael, and hi everybody. It's fantastic to be here this afternoon after a brilliant week of events, and I hope many of you have had a chance to dip into some of those. I certainly have, and they've been, or listened to those, have been great. I'm a Health Inequalities Lead at NHS England and NHS Improvement, and my role is to look at the role of the NHS in contributing to the wider determinants of health, including anchors. So I have, I think, a fantastic and exciting role helping to support and inspire the NHS to be an anchor and to work in partnership, and also sort of look at other aspects that the NHS can do around social determinants and poverty. So really exciting role, and I guess a part of the team with the Health Foundation who's helped to create the learning network that we're part of today, which is great. Things I'm excited about. I think at the moment it's just how much enthusiasm and energy there is for this agenda. I suppose when I joined the NHS about 8 years ago, this was what I thought I was joining to talk about, and it was, you actually couldn't get really people to talk about it then, even though lots of other people were doing it. So I'm really excited that it feels a little bit that the sort of time is ripe now to try and really get the NHS on board and thinking about what we can do to optimise our impact to support communities and benefit communities beyond the direct health and care. And so I think that for me is the biggest opportunity. There are so many areas of impact that we can make, and each I think has to be dependent on your place and location about what the priority is. But I think there's a real opportunity to see for the NHS to recognise itself and to be seen as not just a service, but something that creates health and well-being as well, and to be much more outward focused and be part of the community and be seen as well, optimise everything it can do to support health and well-being.
Great. So Michael, same question to you.
Thanks, William. Hi, everyone. Great to hear from Sara and to be alongside Julia again. So I have two roles. I have a national role working for the NHS Confederation, which is a national membership body for NHS organisations, and that's a role looking at the joins between health and the local economy. And through that, you know, normally would be getting on trains all over the country, trying to understand what local partnerships look like, what we can do to support local people who want to live this local example of place leadership, sit on a few other boards, such as the Civic University Network, which is in effect an anchor network for universities as well. So lots of read across there. On secondment to NHS London, advising on the development of an anchor network in the capital for the NHS. Lots of fascinating learning from that. Happy to talk about that today as well, William, in the questions. I think for me, in terms of the opportunity and, you know, why it's exciting, you're witnessing lots of NHS, particularly from an NHS perspective, lots of conversations about the new governance of the new structures coming in the white paper. And we all know that sometimes we can go down a governance route which almost squeezes the very enjoyment and energy from actually what we want to achieve. And the irony of that, of course, is places where there's most energy, because that's where you can achieve most with partners. So what I'm excited about is if we are going to have these discussions about governance, and yes, we must, that the anchor work is almost a sort of social movement, you know, the counterbalance to that. And actually, they both need each other, don't they? You know, we need to change, we need to understand what our business as usual looks like and how we work, but we need to keep the energy of local partnerships and what we can achieve. So that's my sort of, that's what excites me. I think the opportunity to engage the communities and understand more about them and is absolutely massive. And I'm a great one for, there are a whole host of different boards out there, which actually lots of tables that the NHS should be sat around. And I think what, you know, one thing that really interests me is which of the tables locally and nationally we should have representation on.
Thanks, Michael. So Julia.
Hi, thanks, William, and hello, everyone. Lovely to see you, see some familiar faces from different events this week and also some new ones. I suppose I come at the anchors agenda from three different perspectives. A couple of years ago, I was lucky enough to have a research fellowship looking at anchor institutions in North America and Australia. So I spent 8 or so weeks back in the days when you could get on a plane without too much bother, talking to leaders of anchor institutions and hearing about the strategies they were deploying and meeting amazing people from kind of CEOs to estates managers to procurement officers. And I got hugely enthusiastic about this agenda, and am now really lucky to be working with the Helm team, with the Innovation Unit and NHS England and the Health Foundation to help facilitate and deliver the National Learning Network. I also have an associate lay member role in the NHS with a place-based partnership in Tower Hamlets Together. And that role has recently expanded. It was for the last few years around patient and public involvement. It's now expanded to cover sustainability and equalities, and anchors is a big part of that. And so I'm doing kind of some of the doing as well in real life. And it is not easy, you know, making partnerships take action on this kind of stuff takes really hard work, and I'm learning a lot as I go through that. So I wear a few different hats, I suppose. And I think what really excites me about this agenda is, one, the kind of new leadership we see emerging to talk about how we take action on the determinants of health. So, you know, over the last 10 years or so, I'd say most of the people I've heard talking about how we tackle inequalities have been heads of policy, heads of strategy, people in the kind of executive teams of large NHS and health and care organizations. And I think what we've seen this week and more recently with the kind of anchors movement are people from some of the corporate functions that keep these organizations running, who are becoming increasingly connected to the places they're based in. So people who work in procurement, who work in estates, who work in HR, many of whom have been doing a lot of this work for years, but are really starting to kind of gain a profile and have now hopefully a really wonderful learning network to support them. So really excited about the kind of leadership we're seeing in newer spaces. I also think something that's been particularly exciting this week is the data that some organizations are starting to collect and share, which gives them a much clearer sense of what they do with partners in place. And some of the data we've seen, people from different HR and workforce and strategy teams, as well as some of the procurement teams who've spoken in events this week, has been really, really interesting and very, very helpful in terms of helping them focus their work as anchors and figure out what they can start with, so what their starting points, but also where could they make a really big difference. So yeah, those are some of the things that have fired me up this week so far.
Amazing. So I'm going to leap straight to questions, and please just answer away. I'm not going to sort of give them to any of you in particular unless they're specifically asking for somebody to answer it. But got a question over on Slido, so I'm going to start with this. I mean, you know, it's quite, you know, fair to say, I think in Scotland they've been doing work in this space probably more effectively for longer. This is not something new to them necessarily. I know we heard that from Kathy Cowan at the launch event. So, you know, given that, you know, the debate tends to be dominated at times by England, but that's behind a curve, what do we think we can learn from different devolved nations about this, as opposed to just looking at what's happening in England?
I'm happy to start. I mean, obviously I just think it would be really, first of all, short-sighted to only learn from your own country. I think there's a lot to learn from the devolved nations and internationally, and I don't really understand why you wouldn't do that. There is an awful lot of exciting work going on in Scotland and in Wales, and obviously this week we've heard from America as well, and there's just lots of work both from within the NHS and from other kind of sectors that we can learn from. So for me, it's sort of in terms of specifics, I think in Scotland they've obviously taken a real role in kind of community wealth building and the idea of kind of supporting local economies that I think there's a lot of learning from. There's a lot of work around kind of work with communities and community engagement in Scotland, which I also is something that I think we need to get better at England in how we do that and take a much more sort of asset-based approach and building and working with our communities, not doing to them. And I think in Wales they've really obviously adopted the kind of approach about, like in New Zealand and so on, about the idea of happiness and the importance of well-being. And I think that's sort of some specifics I think we can learn. But just peers, the more we learn from each other and build on good practice, just makes sense to me. It shouldn't matter which nation we're in.
And just building on that, William, so the Confederation has a Welsh office and a Northern Irish office, and I've spent some time there. You know, you look at Wales, for example, which is coming up to an election. Over half of the budget for that devolved administration spent on health. So if you wanted a clear alignment between the NHS and the economy, well, Wales is it. And you can imagine in an election year and post that election, I know particularly during PPE and during the COVID, the ministers for the economy and the NHS have been in the same room constantly talking about these issues. But that's a fascinating, and Wales has got the Future Generations Commissioners as a really interesting public policy perspective there. And then hop over to Northern Ireland and talk about community engagement. I mean, you are part of the community there. You have the minister coming in, popping in at some point for a discussion or a coffee. So I think there's something really interesting about this. We get hooked up on England because it's so deep and complex and big and challenging, but actually this is we all want a strong local prosperous economy. Health inequalities is an issue everywhere. We need to make sure this is a four-part UK puzzle of which we have good international links to.
So I don't know if Julia wants to say anything, but I was just thinking as well, particularly around kind of the importance between kind of urban and rural areas as well, and in England and the kind of differences there. And I think on the launch of the Health Anchors Learning Network, we heard around the anchors approaches in Orkney, and it's just really important that we think about the different role of anchors in different settings and contexts, and I think we can really learn a lot from those different contexts, particularly in Wales and Scotland, where there is so much rural areas, as there is of course in England and Northern Ireland. But
I was just going to, I mean, Michael said it, but I was also going to say, I think the Wales Future Generations Act is a really powerful piece of policy that gives a lot of space and scope for local organisations to take anchor approaches. And I think, you know, we have some different pieces of policy that enable people in different ways, but I think that is more kind of comprehensive and really interesting piece of policy to support anchor work. And Scotland has got some really stunning examples of community wealth building and action, as you said, Sara, and Northern Ireland has had some really wonderful universities kind of coming forward and writing about what it means to be an anchor, some really high profile writers there. So yeah, I mean, I think there are some really fabulous examples from all across the UK that we can draw on.
So we've got quite a few questions coming in now. So I'm just going to put a few things out here and get you to just generally give some thoughts on them rather than, you know, just do one question at a time, because there's quite a few coming in. I've got a couple of questions about, one directly responding to your point, Michael, about, you know, well, if we need to be at tables, which tables? I think, Tim, you've also put up a question about how do we get linked into those local economic development strategies and action plans? So something about like, you know, how do you do it? There's a great question in our life, which is, why do we always have to lead in the NHS? Why can't we follow and support and compound and build? So I'd love to get your thoughts on that as well. And then finally, Lewis had put in chat about they're doing some great work up in Newcastle, but, you know, almost with a sense of how do you turbocharge that into a more strategic approach rather than sort of initiatives, if you like. So lots in there, but if we could perhaps have a look at tables, how you get into local partnerships, perhaps being a little bit humble, and also something about how to turn from initiative-itis into complex strategic approaches.
Shall I talk about tables and link into that things like local industrial strategies and some of the strategies? And so my first job, actually, talk about tables, my first job way back in the day, I'm afraid to say, was for an MEP in Brussels. And the sort of mantra in Brussels was, you know, if you're not around the table, you're on the menu. Now, it's not entirely, a similar approach here, but so that's always had me thinking from a sense of, you know, working for a politician who actually has no autonomy, and all your power comes from relationships, you know, and that dynamic. So that sort of always guided me. But for example, you know, if I was to go around the country and look at, you know, the board of a local enterprise partnership, who in lots of parts of the country will be the body that pulls together that strategic economic plan. There's probably about 5 who would have NHS representation around the board. You know, local enterprise partnerships will also be the body responsible for skills advisory panels, which will have all your training providers, college and university and private, around the same table, working out where the gaps are and how to engage with employers. Again, that's an absolutely obvious link there. So there's something about, you know, and let's look at things like town deals. You know, all the town deals, the government 101 town deals, each one of those towns will have a town board. And this town's board will be made up of statutory and non-statutory partners trying to understand and come together and agree to priorities for investment for that place. So there are a range of tables that health in its broad concept may be understood, but because we're not there to argue and articulate, is it being understood in a way in which we think it should be? And these tables are the ones who are coming up with your industrial strategy for your area, your economic plan, your spatial plan. And what's really interesting, the opportunity here is COVID, as you know, and the changing government has put a pause on the industrial strategy from a national perspective. So I would expect there's an awful lot of work being undertaken locally that will stand as an evidence base there. But when the COVID paint is applied to our national and local industrial strategies, that will equate to a clear role for health in there as that economic stimulant. So what happens in our places now to put health, and that's with what, you know, with us joining the table at the heart of going forward. So I'll just wrap a few questions there together, William, and happy to come back to those points.
Can I add something to what Michael's saying? I fully agree with everything he said. And I think actually, obviously, most of the action really needs to happen at that place level. And there's a real recognition within I think the NHS and colleagues within the NHS need to kind of recognise their own role. And I think it's also true, we hear sometimes people don't quite know who it is, whose responsibility it is. And so there's something around that that needs thinking through. But there's also another thing about kind of other people recognising the NHS as having a role. We certainly need to do more, but I think sometimes it's not considered, and I think that's both at a local level but also at a national level. And I think that's where in sort of colleagues in my role, particularly around kind of health inequalities and placemaking, we've got a real, and the levelling up agenda, we've got a real role to influence government and get people to actually recognise the role of the NHS. Recently have been linking in with colleagues in the Social Mobility Commission, and they, for example, have been doing some work on social mobility in public services, and the NHS wasn't considered. And you think, we're the biggest employer, we're everywhere, and we're just not considered necessarily as part of that. So I think there's something about us putting ourselves at the table and also sort of shouting, like being willing to be part of the table, and sort of hearing, sort of reflecting on the question of not always wanting to lead, but also being seen to be important part of that, and that we've got a significant contribution, whether it's in the new kind of growth plan or levelling up plans, that we have a real role beyond providing health services.
And just to add to that, I think there is something I've been noticing locally, which is potentially a gap in our governance and leadership around this. So I think, you know, a lot of the integrated care partnerships and the borough-based or county-based partnerships of health and care organizations, you know, the big anchors in an area, the leadership teams coming together often on a kind of monthly basis, sometimes during COVID much more frequently. They are chief executives and or kind of directors of services or commissioning. And I think the areas, the kind of key strategies that we talk about with anchors are often more linked to corporate leadership or commercial services, or you know, in the States, certainly when I was out there, you'd have a kind of chief administrative officer or chief operating officer, and they would be the most senior accountable executive director who would be leading some of these functions. And those people don't meet around the table. So, you know, in City and Hackney, where I'm doing some work with a local network, the chief executives and a lot of the kind of directors of commissioning meet, but their counterparts, the kind of directors of corporate services, don't meet in an equivalent way. And I think there is something about the kind of collective leadership of this that needs a bit more in that space as well. And then, of course, in wider areas, you might have housing association, policing services, fire services, higher education. They might be meeting, as Michael's saying, in a different, you know, structure, and health may often not be there. There's only so many meetings you can go to in a day, obviously, but it is interesting, you know, I think it is about being tapped into some of those local conversations which aren't directly about the health and care partnerships, because that's where some of this work is happening.
Yeah, and I think and I go back to kind of what's exciting me the most is about sort of the time being ripe, really, is you know, having kind of been around for a longer than I care to admit, around kind of what was called regeneration and so on. You know, 20 years ago, health wasn't there, and now we've seen, not to bring a kind of policy context into it, but the kind of new policy for ICS, one of the key roles for an ICS is the recognition that the NHS has a role to play in economic and social development as a fundamental role. So I think that's really important and will really help lever some of this change. But completely agree, Julia, it's also kind of finding some of the right people to make decisions and to be involved, whether it's about our own direct impacts or being at the table to sort of be involved in whether it's planning, regeneration, estates or employment and so on.
So I'm going to come back to the issue of local versus regional versus national, because that's been a theme in some of the discussions throughout the week, actually. So I'm going to come back to that in a bit, but just before we get there, and so also picking up this piece about moving from initiatives to programs of work, or making this the strategy rather than part of the strategy. I've got a couple of questions in Slido. One is about, who's got good charters, and obviously earlier this week we looked at the Leeds Charter. I know there's some others out there as well, so it'd be interesting to get your thoughts on sort of the value of those charters and how you start to embed them. But also, like, there's a great question about what are the key success factors. What are the things that are going to make you successful in delivering this agenda? And, is there anything we can learn from the people who've started, whether it be in the NHS or wider?
Well, I will put a plug in for the North East London Charter, which I was involved in developing and which I think is not bad. It is a kind of set of principles, but also there's some kind of associated metrics work coming out. And you know, in many ways it's been influenced by charters, but both the Leeds kind of reflection framework, which is a helpful structure to help organize thinking and action in this space. But more importantly, as a process, it was a process through which all of the partners in the ICS in North East London got the chance to talk about, what does this mean for my organisation? What are our starting points? What work have we already done on this? What data is it possible to collect? What data is it not going to be possible to collect? So it's a kind of helpful process to go through in order to understand what your starting points are and what kind of ambition you have as a system. I think where I'd like it to go next would be that it is the kind of charter that is being reported on regularly at the kind of ICS governance level, and that the executive and the kind of oversight functions are really familiar with the statistics, they're really familiar with the level of ambition, that people leading work streams linked to the charter are reporting back on that. So it's a very active piece of work, rather than, I think in some cases, charters, even though they can still be very good charters, become a kind of statement of intent, but they're not actively used to monitor performance. And I think it can be very helpful as a kind of data gathering and performance management tool as well. So I'll put a plug in for North East London.
Yeah, and I mean, I'll plug a couple of others, and then I'll kind of pick up on the wider points about accountability that Julia was talking about. So I think Cheshire and Merseyside have got quite an interesting approach. They actually call it a social value charter. So there's a whole thing about language we could get into here, but they mean around kind of environmental, social, economic impacts. And they've really done that cross-sectorally. So they're working with the council and corporate and voluntary sector are all part of that charter. And they've put in place quite a lot of training and support to do that. And they've also got an award programme on the back of it. So they can kind of almost have that kind of, I suppose, assurance stamp mark, and also celebrating good practice. But there is certainly all sorts of other systems and local places like Morecambe Bay are beginning to develop charters, and Suffolk, North East Essex have also got quite a good one. And just reflecting on that, we've been challenged of, should we have a national one, a national framework? And to me, we could provide potentially some framework, but I think, as Julia was alluding to, there's something about going through the process and thinking about what's important for your area, your system, getting the buy-in from partners from cross sector, so it's owned and developed. And I think the point that Julie was making around kind of that accountability and using it to report on, I think is really important, both at a kind of individual organisational level. There can be a lot of noise and a lot of activity, but are you really making a difference, which perhaps comes on to another discussion about impact and reporting and so on. But I think there's also something around, I often hear people don't want it to be a should do, it's got to be a must do. And there's something about really signifying that, and also it being part of the heart and culture of what we do. We don't just want, yes, it's really important that our services and waiting times and access and so on and the health outcomes are measured, but there's something about us being really responsible and really recognizing it as both something that we can do, should do, and want to do.
And just to say, I mean, there's some great examples of charters, and Gwenel's making them public, and Lewis joining from Newcastle. I mean, another great example from Newcastle, the Collaborative Newcastle example, which there's a website for it too, isn't there, Lewis? Which, what's fascinating about Newcastle, if I speak to Dame Jackie at the Trust, or Chris Day at the university, Pat Richard at the council, they speak on behalf of each other. They speak about Newcastle. You can have anyone in a room, they will tell you the same thing. And they've developed a culture for the city. And actually that brings us on to this issue of place reputation. We all know, we've all suffered at a point from place reputation. It could be trying to attract good staff. It could be, we've all suffered from place reputation. And sometimes maybe that's felt unfair, but actually it shows us that we have a part to play in place reputation. And actually that's some of the softer measures of what we're trying to do. There's plenty of hard measures here. I think what we have to guard against sometimes is we've all seen sectoral measures which are almost disconnected from the success of our place. So if I can be successful and yet my place has become poorer, the health of my population's become poorer, then why am I successful? You know, so there is some of these places where we're coming together now with the charters and other partnerships. It really is about trying to understand what the metrics are for that place rather than for that sector.
Yeah, and to add, I think there's something really important about the anecdotal evidence, the stories, because that's also really important for people actually emotionally connecting to it and understanding it and seeing the difference. And also numbers don't, while they are absolutely important, they don't always capture everything. And I think, you know, not everything can be turned into a number. And I think also it's just a fantastic way of communicating. And if we want to be part of the community and being part of the wider society, stories are great for that.
So so picking up on sort of another question we've got then in here, I mean, you know, I've been involved in quite a few conversations over the last few weeks with sort of anchors in other other sectors rather than health, and they talk about the importance of capital in this, so capital investment and capital opportunities, whether that's rebuilding or not. And they also talk about how, you know, the Treasury approach to some of that doesn't really help. And there's a question in the slide about what support anchor institutions should expect both at a national and local level from government. So, you know, how do you get governments to make this easier? Because there is a version of this where, you know, if you want to build homes, for example, it's harder than ever to do that at the moment because of the way that capital flows in the system. So what is it we need and should we be getting from government to make this work?
Well, I mean, from an NHS perspective, are we confident that the Treasury sees us as an investment, or do we think the Treasury sees us as a cost? Now, I'm not entirely confident if I walk into the Treasury today, they would welcome me in open arms and say, this is a great use, you know, this is a great investment. This is what I'm expecting back from you. Now, part of that is about our behaviours and how we pitch ourselves and how we join these conversations up. You know, you've seen the Green Book has been had a review late last year. You know, how many of our own capital projects in the NHS start with a true open look at the strategic objectives we're trying to achieve, how they link into the wider economic and social regeneration of a place and that success of a place. So if we ourselves are not pitching health as part of a place's core investment, then why should others see that? You know, so that's clearly an argument we need to have. We're far better having that with our partners. So, you know, the thing about capital is it's a massive opportunity, isn't it? If I could click my fingers, it would be that every HIP project or whatever we want to call it needs to show the full economic and social value of it. I would ask, you know, there's almost a duty to cooperate, which is a duty to talk to our partners about how to maximize the opportunities. How do we look at, you know, we're going to move to a model perhaps of devolution and fiscal devolution. You could have mayoral bonds, rather like in America, rebuilding our places. Where's the, you know, where are we in this journey? So I'm a bit worried that we're having sector specific capital discussions, which reinforces the haves and the have-nots, rather than actually looking at what the underwiring, the economic underwiring of a place is going forward. So that's my starter for 10, but maybe we'll come back to this.
Yeah, and I know this, we're building on that, and it doesn't fully answer the question about what the government should or shouldn't do. But I think there's also a need to for them to sort of recognise health as well. So Michael and I have been talking around some of the kind of large spatial plans that government is supporting, and they're about economic development. And where's health? Health isn't talked about. So we're working with colleagues to try and go health and wealth, health and economy. It's two sides of the same coin. And also, can we look at health through the health lens as that? And what more evidence do we need than the pandemic to show the importance of health for our economy and the economy for our health, really? Sadly, it's obviously kind of fully highlighted and exacerbated the inequalities and issues in society. I think I just wanted to pick up on one thing that the government has been doing. I mean, obviously the whole levelling up agenda is something that we can help utilise and frame, and for the NHS to be seen and have a role, and also take advantage of some of the funds that are coming out and being a partner in that. But one area the government has made some strides on is their recent commitment to social value in procurement, and how we can build on that as a sort of public agency. Don't quote me on this, I actually don't think we're fully obliged to do it, but we are going to follow that. And it's really helpful that the government has set out this commitment to social value. But yeah, and I think I think the question was also about what we can do nationally. There is obviously, I think, some deeper issues that we need to think through and are very topical around how resources are allocated across health and care. And we're very much thinking about that in the Health Inequalities team, of how resources are allocated in certain areas where there may be more deprivation or issues, how we focus investment in that, but also about making long-term commitments, and the annual budget cycle is not always helpful.
I mean, I would just add, and then before we go on to some of the other questions, I think there is always more that government at both regional and national and local can do to provide a kind of supportive context and to remove barriers. I think what excites me most about the Anchors agenda, though, is that it is just about how much you can do with what you already have. And so many of the conversations we've had this week have been about people whose day-to-day work as anchor organisations in health, or in the NHS and in local authorities and housing and higher education, are using the hundreds of millions of pounds worth of budget they have to do things differently and to redirect that spending, to think about the way they recruit their workforce and progress people through the workforce. So yes, of course, there can always be more support, but I think there is just such a huge amount we could be doing already, that I think that's what I find quite exciting, is that we don't have to wait for anyone else. There's a lot we can just get cracking with right away.
So moving then on a bit to sort of, one of the tensions we've seen this week about kind of, a lot of people saying this is a local challenge, right? So anchors are about being in a place and it's about local. I mean, that's tricky when you're a National Health Service, right? And the movement to ICSs pushes you away from local place. How do you think we're going to sort of manage some of that tension? Because the history of the NHS is littered with initiatives that don't take off or get stymied by marking your homework at every level. So how do we use this as an opportunity rather than perhaps a problem?
I think there's something about recognising, well, in terms of the sort of tension between the different levels, I think there's a role for every level of the system, if you want to call it, right down from the individual level. Everybody's a leader, everybody can advocate, everybody's got something they can personally commit. And Michael referred to the sense about social movement is actually the biggest asset is people, whether it's within the NHS, within the community, and of course staff within the NHS are members of the community. And then there's a specific role at a kind of localised level. We've seen emerging activity happening in primary care networks around anchors, some fantastic work in Fleetwood going on in Lancashire. And then obviously a place level is really important. It's coming up in this interaction between different anchors at place and being part of the community, understanding the joint priorities that different anchors can work with, obviously directed by community and voluntary sector and other partners work with. And then we're beginning to see an emerging role for I've missed out systems. Obviously we've talked about the role of ICSs. I think there's a really important role for systems to support individual anchors, also to act as a convener, to help share information, possibly to help set some larger priorities and sort of baseline and measurement across the system. But also there is some real advantages to tackling issues at a system level and sort of bringing together joint action and as we've heard around the charters emerging. And I think that's echoed again at the regional level. And I know Michael can certainly speak more about the fantastic work that's going on in London at a regional level, where the region is making a commitment to this, and we're within the other 6 regions that the NHS uses. Again, we're beginning to see emerging approaches about understanding what is that regional approach. Is it about supporting, convening, or also kind of providing some sort of accountability and connection into the national. We've talked about the national role, I think particularly around spreading and scaling, and innovate, helping to kind of get things going, and sharing it and supporting, but also influencing upwards. There was a second part to the question that I'm so busy talking about different roles I've forgotten about. I've forgotten what it was, but I did have an answer to it, but I'll perhaps let somebody else come in and then I might come back to it.
If I just mention the London, and Julie will have an interesting view of this, because as a lay member, someone who works at a system level in London too, it's fascinating. I think normally with health policy, it's sort of, we always often feel that health policy comes from above. And I often think with anchors and this strategy, it's actually about starting on the ground and every tier above that almost having to justify its added value, which is quite a different, and that's exciting actually, because that means that, you know, you can move as far and as fast as you can locally without anyone holding back. But London's interesting. So there's lots of work going on the ground. There's lots of fantastic system work going on. And then you've got the region, which is what, an economic and democratic geography. So there's, in talking to NHS leaders within London and system leaders, it's what is the added value of London? Well, there's clearly something about using the arm of the mayor and using, you know, that the convening power there that links into other sectors. There's something about lobbying and influence. We can have amazing change on the ground, but if you want to change policy, it has to, you know, it has to be brought at a higher level. There's something about resourcing. Lobbying kept coming up. I mean, you know, how many times has the apprenticeship levy caused us headaches at institutional level? And yet, actually, what can we do at institutional level? Not much. So there's a really interesting, you know, sort of, you know, London is a great example of how humble at every level we are, but where we are clearly marking out, you know, the branding, the communications, the reach and the role of every tier. And, you know, the heavy lifting may well happen with Julia in North East London, but we know that London are facing the same, where they're supporting and cajoling and challenging and coming up with some of those big issues, which we think that we can, when a new mayor's in post, we can really move on. So I think it's about adding value, isn't it? You know, yeah. From on the ground up to Sara, NHS England, what is that added value at every level and how are we contributing to this?
And I think that one of the biggest challenges probably for the NHS working as an anchor and figuring out, it is going to be figuring out at what scale it does what, because there are lots of different layers now, and, you know, the ICS footprints don't necessarily marry up that well with other anchors, some of whom will go by traditional local government boundaries, some of whom will be more hyperlocal, some of whom, like arts and cultural institutions, might span across a whole other geography, and housing associations likewise. Some will be very defined as a boundary, some will be much more dispersed. I mean, William, I know you can talk about this. So I think there is something really interesting about at what scale do you do what, and at what scale do you focus your effort on partnerships and delivery. I think it's really interesting that there's a reason why my associate lay member role is boundaried by the borough of Tower Hamlets rather than the North East London STP. And that's because that's where we have our strongest borough partnership. That's where we can do a lot of engagement with local businesses who often identify and are engaged by a local authority boundary. And it's where the population identifies. I mean, I think, you know, certainly in London, there's a real London identity, but then people do often identify at the borough level and at the sub-borough level within kind of more micro spots. And so there's different things you do at different levels. So if I think about North East London, if I, in the NHS, want to do something really big on estates and use that as a major anchor strategy, I'm probably going to have to go to the ICS level. That kind of governance and that delivery is going in at, you know, the whole of North East London. If I want to do something around workforce and thinking about building relationships with local schools and colleges and universities, I might well do it at the borough level, because that's where a lot of our stronger relationships are. And we can have a conversation about what does it mean to be a young person growing up in Tower Hamlets? What do you think, you know, we're having a really interesting discussion at the moment about representation in the workforce and how we do engage more with local schools and colleges. And so I don't think it's an either or. And I think different anchor strategies lend themselves to different scales of intervention. But it is a challenge for the NHS that its scales that it's moving to don't always correlate with where the partners identify.
Yeah, and I have remembered the second part of the question is around kind of making it strategic rather than initiatives. But just before we move on to that, I was going to add the other role at a national level is to really So a lot of my day job is around kind of poking other policy teams. That's what I call it. I'm sure it's more about influencing, but it's like saying to our employment team, how are you thinking about workforce supply and social goals? Or talking to our estates team about how are you thinking about new hospitals and benefiting the wider community by and supporting regeneration and so on. So there's a real role we can play there to unlock some of the barriers at a national level as well. But I think the second half of the question was really about how do we move from that kind of lots of initiatives to making it more strategic. And I think that again needs to happen in different levels. There was a question around leadership and kind of that really getting that commitment and that culture and seeing it as part of the strategy. And I know some of that you might need to kind of then start evidencing to, I think I heard one of the speakers speak earlier in the week about, I think it was the racial inequalities one, mention nobody would say this isn't a good idea, but there's loads more to do. So other things that we need to get on with. So there's something around what's your evidence, what's them seeing that it benefits, the other benefits it brings to the health service, what are the mechanisms to influence, and then I guess trying to find the right leader and to inspire, bring people with you, but then getting it embedded into that kind of governance and strategy is really important.
So I'm going to
just William,
go on,
before you
Michael.
say,
Yeah, go.
Julia mentioned identity, you know, and I think the NHS ignores identity at its peril when talking about place. You know, it's so rich and it's so, you know, and it causes us issues, but we can't just draw lines around certain areas and ignore identity. I think that's a really interesting point.
And I've got one more point, if I may. I'm really sorry.
Go on,
then,
I'm going to indulge you.
Yeah, the fact that you know, there's such an opportunity for anchors to sort of support and contribute to tackling health inequalities, and I think really given that there's so much focus on inequalities at the moment as well, perhaps also kind of framing it within that context will really help position it in a kind of, you know, again, I've heard it never used to be talked about at board levels, and now it's talked about a lot, and again sadly because of the pandemic, but I suppose if that's a positive and a kind of a benefit of the pandemic is that we've got an opportunity to really help tackle inequalities here and positioning anchors as part of that.
So I've got one more question I'm going to ask, then I've got a question for the three of you, but also for the wider group of people. So if you're on the chat, we'd welcome your views as well. So the last question from the audience we're going to go for here is, I mean, this all sounds great. It sounds positive. You're all talking this up, right? It's a halcyon, sunlit uplands that we're going to if we adopt an anchor mission. But there's a great question here, which is like, you know, can you think of any potential negative unintended consequences that may arise as a result of doing this?
What I would, shall I go? I mean, what I would say, William, we are making decisions every day, many of which are place blind. So actually, who is to say that many of the decisions our boards are taking are actually benefiting their local area? Are they leading to the detriment of their local area? You know, place blind policy equals rootless actions, you know, to say that. So I think this whole journey, it's not about being an anchor. You know, we mattered yesterday, we matter today, we matter tomorrow. This is about understanding quite how and what and where and why, you know. So what I would say is, you know, I've come across many, I won't name them, but many decisions which we've taken which have actively made our partners' jobs harder and which have actively made our economies and communities poorer. And I know of several. So this isn't, you know, so this is about understanding, I think, who we are and what we do.
And I mean, I think that a classic example of where you could have a negative impact is around, you know, when you might have good intentions to implement, for example, social value in procurement, and then inadvertently cut out the voluntary and community sector or put them on a back foot around kind of winning a contract or something. So there's some really careful thinking in that. There's also an opportunity to influence in a positive way. And I guess everything can have an unintended consequence, every action we do, but one way that we can help avoid doing that is by working co-productively. And I know that's a kind of that's got to have some meaning, but if we're really thinking through with our partners, with our communities, with cross sectors about what the priorities are and what the implications are, and the kind of a proper strategic process for thinking that through and asking what am I trying to achieve, what would the impact of that be, in a kind of proper, almost seeing risk as a positive way of thinking, and doing that in a kind of co-productive way. I think we can at least try and minimize some of that.
Yeah, I mean, I agree. I think there's a bit of an incumbency bias that we assume that what we're doing now is a good starting point. And I agree, I'm not sure we're starting from the strongest place with some of this stuff. And as Sara says, of course, there will be some unintended consequences. And I think for me, this is a real test and learn approach. And one of the things that I've been quite excited about recently in Tower Hamlets, where we have some organizations such as ELF that have really strong quality improvement expertise, is thinking about applying that kind of quality improvement methodology. So doing rapid learning cycles, gathering data, reflecting, learning, testing things out in small ways in order to learn before we apply it to the biggest contract we have, or, and I think that is one way. Thank you, Gwenno, East London Foundation Trust. Yeah, that is one way in which I think we can kind of mitigate potentially some of the bigger risks if we do the kind of go big or go home approach first off the bat.
So I'm going to bring us to our last question for you all now, and I'd like you all to answer, and nice snappy answers, please. Gwenno is also sharing your screen, so for you sitting at home or in the office on this lovely sunny Friday afternoon, we'd like you to go over to www.slido.com, #HALN5. And the question up there is what advice would you give to others based on your experience working in or with anchors? And we're looking at something pithy because people want to know what they can do, how can get on, what's the one bit of advice you would give. And please at home, do type into the screen so that we can see your answers as well, because we'd love to be able to have a moment to share those. So I'm going to come first to opposite way this time. Julia first, then Michael, then Sara.
I mean, I am going to do two things. One is data. Doesn't have to be the biggest selection of data you've ever had, but getting some baseline data that gives you a sense of what your starting point is invaluable. And I think a lot of anchors have found that a really rich process that's helped direct their attention. I think the second is having a laser-like focus. And so Dr. Ansell, who we had on the session yesterday in tackling racial inequalities, is always really powerful when he speaks about you've got to know what the gap you're trying to narrow is. You've got to know what it is you're trying to tackle and be really, really specific about that. Otherwise, you can do a lot of stuff and not really know where it lands. So I think for me, there is something, and some of the anchors I've met that are most advanced in their practice, in their thinking and in their impact are very crystal clear about who they want to benefit and who they're trying to reach, or which particular kind of streets or ward or area they want to benefit. So getting that clarity, I think, is so important. That would be my tuppence.
I think for me, and I'm sure it's come up, we talk about co-production. When we meet our partners, do not have an agenda. Part of this whole journey is connectiveness, and that's connectivity within our own institutions, which is in itself a challenge, but connectivity with local partners. We are not sitting down with our universities, our colleges, our housing associations with a formal agenda. We are exploring who they are, what we can do to support them, what success looks like for our project. So there's a relationship building piece here, which if anyone comes with an agenda, that's not a relationship building piece. So there's something about exploring each other and understanding what's already happening. Where are we? Where can we add value? So, we do not need to formalize this. We can, but we do not need to. So I think that's quite a challenge, particularly if you've been to NHS, meetings, which is agenda, formal. Go and sit down and understand what our ask and offer is of each other.
And I agree with both Julia and Michael, and I think there's something about what they're both probably saying in something around that is kind of really beginning to focus on your priority, what's a priority, and sort of noting something in the chat about us being late to the party is I agree. So it's, as Michael said, working with other partners and being open to that agenda. I suppose to add something a bit different, while I absolutely think you need to focus on priorities, I think there's something about being opportunistic and building momentum, and that is certainly going where the energy is, certainly if you're working in partnership, because small things can grow out of the seed. I suppose be prepared to take a risk, be creative. I mean, I completely relate to the point that Michael said about connections, is, you know, talk to people, be open, and something will happen, and you know, that energy and that momentum will help build onto, perhaps, you know, it might not be your absolute priority issue initially, but that will give you the platform to really know, to help you build getting to where you want to go with. But it is important to know what your priorities are. But I guess every anchor is in a different situation, a different leadership, a different geographic context. So I suppose it's working out what's right for you in your place as well.
And resourcing, isn't it, Sara and
Yeah.
Julie? You'll see
resources, and don't feel you're alone, and that's kind of really the purpose of the Health Anchors Learning Network as well. You know, there are lots of people interested in this agenda. There's, as part of the network, there's a forum, a platform. You can ask any of us for, you know, get in touch with us through different mechanisms for advice or support, speak to other people and learn from others.
Amazing. So I think as well, if you get a chance, have a look at the answers on the screen of slide. There's some amazing stuff in there. Really good stuff to build on there. So I'm going to bring us to a close because it's a beautiful sunny afternoon, and I believe that the beach is calling me shortly for a glass of wine and maybe even a bag of chips and a donut. But just to thank my three speakers today, Sara, Julia and Michael. I think everybody agree that was just fascinating wealth of stuff we could have talked all day. Also, thank you to those of you who've been here throughout the session. Been really great to see you all this week. And we've just got one last task for you, everybody, which is please just take a moment to feed this poll feedback. There's 3 questions, take you a few seconds, just to give us a sense of whether this was any good, work you've been to this week, and whether or not this was kind of too long, too short, or just about right in the Goldilocks question. So do answer the questions for us. Once you've done that, thank you so much. I hope you'll have a brilliant weekend. See you soon.